Hello and good evening to all of you, and a very warm welcome in today's session. So, I hope all of you are doing fine. Is my voice clear and audible?
Yes, ma'am.
Yes, ma'am.
Fine. All right. So, it will be a short session, structured discussion task on precocious puberty. The scenario came in the exam, okay, and there was a TOG. I mean, there is a TOG, of course, and it's a very important scenario. It can be repeated. So, it's an important scenario not only from the examination point of view, but also we see such cases, young girls with precocious puberty in our clinical practice as well. All right, so I think volunteers have also joined, right? Okay.
Yes, ma'am.
Okay. I'll show the scenario. Please take it easy, okay? This will be just like discussion and, of course, presentation as well. See the scenario and the question. Now I have 3 questions. I will need 3 volunteers to answer each questions one by one, and you will get 3 minutes to answer the question. So who would like to come first? Okay, read the scenario first, okay, and then just volunteer. Give me your names, please.
Hello, ma'am.
I'm Khushbu.
Sindhu.
Khushbu, Sindhu,
Divya.
Divya, anyone else? Okay, fine.
Yes, ma'am. Kazi, I mentioned before in the group.
Kazi, right. So after these 3 questions, I have few more questions in the end, okay? We will be discussing the management of isolated variants, peripheral precocious puberty also. So for that also, I will need a volunteer. So who said first? Khushbu, all right. Then Sindhu.
Yes, ma'am.
And third name?
Divya, ma'am.
Divya. And then we have Kazi Mahmood, right. All of you will get the chance. Please don't worry. Okay. So Khushbu, can you take the first question? Read your task.
Yes, ma'am.
Yeah. Take your 1 minute is enough. I think you will just have to answer one question. Okay. And I'll give you 3 minutes. Okay. Organize your thoughts. Your time starts now.
Yes, ma'am.
Okay.
Should I start it like, ma'am, structure discussion?
Yes, dear. Just like structured discussion. But you will do question number 1 only. All right.
Okay, ma'am. Should I start, ma'am?
Yeah, start please if you're ready. You will get 3 minutes, okay? So,
3 minutes for question number 1.
yes. Yeah.
Okay.
Of course, I'll be asking few questions in between. Go on, please.
Yes.
Take it very easy, okay? Take it very easy. Start.
Hello, I'm Khushbu, one of the exam candidate. I have gone through the scenario and ready to start the discussion. So I've been provided with a case scenario of girl in her 7.5 years of age with well-developed secondary sexual characteristic, and also she has well-developed axillary hair, pubic hair, and thallus, but she has not attained her menstrual cycles. So first of all, I would like to take a brief targeted history, and then would have few more investigations regarding her to make a few differential diagnosis in my mind. So first and foremost, my most important differential diagnosis being here is precocious puberty. Either it could be central precocious puberty or peripheral precocious puberty. The reason being could be either it is because of exogenous estradiol, or it could be related to some central cranial lesions. There is possibility of some adrenal causes like adrenal tumor also, um, and uh, any related ovarian tumor which releases excess of estrogen like granulosa cell tumor. So
Okay, what could be the causes of central precocious puberty?
central precocious puberty can be like any central tumor which is responsible for release of excess amount of follicular stimulating hormone. So either it could be any any tumor in the central lesion like craniopharyngioma. It can be because of then it can be related to any hypothalamic tumor as well, which releases excess amount of GnRH. Maybe it can be related to tumor in the central region that can be like craniopharyngioma or any pituitary tumor which releases excess serum FSH. Another possibility is hydrocephalus, or sometimes because of some radiation therapy also. This is possibility of precocious puberty, or some trauma or some infections like encephalitis, or any drug chemotherapeutic agent can be responsible for this type of lesion.
Very good. And what could be the causes of peripheral precocious puberty?
So regarding peripheral precocious puberty, any lesion which is responsible for excess of either estradiol hormone or either excess of adrenal hormone, like estrogen secreting granulosa cell tumor, because of excess of estrogen, thalarch and other possibilities there, or some androgen secreting tumor like Sertoli Leydig cell tumor can be one possibility. Congenital adrenal hyperplasia of or Cushing syndrome can be responsible for precocious puberty, or maybe there is possibility of some kind of sexual abuse also, or a girl taking estrogen hormone, maybe by mistake, or maybe for some, any of the reason.
Okay, fine. Your time is also up. Okay, and what are the isolated variants? Can you just name them?
Is isolated variant like sometimes it could be just isolated thalarch, or it could be just isolated adrenarche,
Yes.
or it can be just pubarch. So
Yes, absolutely right. Yes,
only a single thing.
yes, well done. Okay. So good. Next. Okay, thank you, Khushbu. We will discuss
Thank you, ma'am.
the answer later on. Okay. Now, who will do the second one?
Sindhu, ma'am.
Sindhu? Yes, Sindhu. 3 minutes for you. Okay, fine.
I should start or?
Yeah, introduce yourself and then you can start. Fine.
Hello, I am Sindhu, one of the exam candidates. I've gone through the candidate's instruction. I'm ready for the structured discussion.
All right. So my question is, how will you gather more information about this girl? Justify your answer.
Yes, well, in this question, firstly, I would like to introduce myself to this girl and confirm her name, age, as in just number. So, after confirming the information, I would like to build a rapport with the girl, and I would like to collect the information both from the mother and the baby, the girl separately. So, I would also like to assure confidentiality with the girl and tell her that everything, whatever we speak, will be confidential unless and until her safety is at stake. Then I would like start assessing her by asking certain information related to the causes, like when she has noticed these changes. Is it gradual ones? Since how many months she is noticing this? Is it a sudden change and a rapid growth to rule out if there's any tumor? And I would like to rule out the other causes starting from the head, like if she has any headache, or if she had any history of seizures, or there could be a blurring of vision, or any history of infections, or any surgeries she has underwent on the head, and whether she had received any radiotherapy. So after ruling out the brain causes, then I would like to rule out whether it is she has any ovarian and adrenal causes, that is whether she has felt any increase in the weight or decrease in the weight, and increase in the appetite, or I mean there is any decrease in the appetite, whether she has felt any lump or heaviness or any bloating sensation. And I would also like to know, rule out thyroidism, hypothyroidism symptoms, like whether she has constipation, intolerance to cold, or increase in the weight gain. And apart from that, we'll also like to know if she has any changes in the skin, like whether she has noticed any patches, brown patches, which is called as scapulate spots. So I would like to rule out the other McCune-Albert syndrome. So I would like to ask that. And apart from that, so the history we'll also ask the mother also has similar history regarding any changes in her psychological or behavior changes she has noticed in her recently, and whether she has discussed all this, or is it having any impact on the girl. So whether she is an adopted child or a biological child. And very sensitively, I would also ask the mother as well as the girl separately whether she is undergoing any sexual assault at home, whom all she does stay with, and how is the studies going on. So after that, I would like to ask a medical condition, whether she's being treated for any medical conditions, and any drug she's being taking, or any medications which contains estrogen, and surgical history, whether she has underwent any surgeries on her abdomen. After that, I would like to know her BMI, and her if she has any allergies, and personal history, if in case if she smokes, and any drug addiction. And apart from that, family history is very important. I would like to know if her siblings also have similar complaints. Anybody in the else in the family has similar complaint. And support is very important. That is whom does she stay with at home. And mental history is very important in this girl, whether it is impacting her quality of life, affecting her studies, emotional changes or not. So once the history is complete, I would like to go ahead with the examination of this girl, starting from head to toe. First, we'll see if there's any changes in the skin, and would like to do her breast examination, like to do her abdominal examination, and we can also offer her other investigations. Should I proceed, ma'am?
Yes. Information gathering is your history, examination, investigation. Yes. Proceed.
Examination, it also includes a neurological examination if she has any headache or blurring of vision. So we can even send her for eye examination, ophthalmological examination, neurological examination, and her abdominal examination. So after that, there are certain specific tests which are done specifically to rule out the causes of this. So it can be either central precocious puberty or peripheral precocious puberty. So we mainly do to see the growth velocity, we usually go ahead with the X-ray of the wrist, mainly the left wrist X-ray. So if it is increased, it means that she is having a central or peripheral precocious puberty. So here we do have one more test called as the gonadotropin stimulation test, where this is considered to be the gold standard, wherein the LH surge will be there, as that is, it will be more than 8 international unit. That is, LHS to FSH ratio will be more than 1, especially in case of central precocious puberty, whereas in peripheral, LH and FSH will remain either borderline, or the GNRH stimulation test will be a flat line.
Yes.
That's all. So LH and FSH will be basically measured in this child.
Okay, so right, GNRH stimulation test, it will help to differentiate also between your central precocious puberty and peripheral precocious puberty. Okay, any other chemical or like biochemical tests would you like to do to find the cause of peripheral
Yeah,
precocious
with respect to adrenal, we can
Yeah.
even go ahead with ACTH, DHEAS,
Mm-hmm.
to denote congenital adrenal hyperplasia.
Right. Okay. I gave you 4 minutes. Actually, this question number 2 and 3 needs 4 minutes. You have to talk a lot. Fine. Okay, Sindhu. Thank you. Now we have Divya. Yes, Divya, come forward, please.
Yes, ma'am.
Okay, you can introduce and start the station.
Hello, I'm Divya, one of the candidates for Part 3 exam. I've read my task and I'm ready for the discussion.
Okay, so from the information which was gathered and from the investigations, this girl has been diagnosed with idiopathic central precocious puberty. How will you manage her?
So, for in case of idiopathic central precocious puberty, first our management will be by a multidisciplinary team of doctors, which will involve the endocrinologist, the adolescent gynecologist, and also the pediatrician. And so, what we would be worried is that we would have to stop this further progression of the secondary sexual characters, and also to prevent the menarche. And another thing is we would have to also stop this early skeletal maturation. So our treatment will be targeting all of this. So the treatment would be GnRH analogs. So this acts by acting on the pituitary by initially it will have flare, and then later there will be desensitization of the receptors and will have down regulation. So we would choose to give leuprolide or triptorelin, and also gosirelin. These are the commonly used drugs. So they can be given intramuscularly or subcutaneously. And depot preparations are also available. And recently there is an implant also, which is histrelin. And the side effects with these drugs will be local side effects, like there can be pain and rashes can be there. And apart from that, systemic side effects like headache, mood swings, and so these are the side effects. And long term also, there can be chances that it can have a polycystic ovaries later. And it is important for us to monitor the growth and also the secondary sexual characters progression. So and we would stop it. The treatment would be continued till 8 years. So once when the natural puberty is there. And apart from that, counseling is also very important. We would have to counsel the both the mother and the child regarding the impact it can have on psychosocial behavior, and also mental status, and also the chance of abuse. So we would have to counsel regarding that, and we would also be counseling them that because this GnRH analogs are used, there can be an initial flare-up of symptoms, and later all the symptoms would get regressed. And emotional and support would also be would have to be taken care of.
Right. How will you monitor the response to GnRH agonist?
So we would have to monitor by doing the X-ray, and also the other secondary sexual characters progression. We would have to be monitoring by the TANA staging. So based on that, we would have to mm, see whether it is responding or not.
Yes, and we will also see the LH measurement, whether there is suppression of LH response with this treatment. Yeah, so that will also indicate that treatment is effective.
Yes.
Okay, anything you want to add? Just few seconds.
So usually these drugs are given over a period of like 3 weeks, monthly ones, and if they are depot preparations, then they can be given 3 monthly ones.
Okay.
So
And what do you think, growth hormone should be added or not?
the little controversial regarding growth hormone and the GnRH agonist to be given together. But if we think that there is stunted growth and there is marked then we can give growth hormone supplementation also.
Right. Okay. All right. Well done, both of you. Okay. So next, okay, Dr. Kazi, the question is not written here, but I'll just ask you because you also volunteered, so you should get the chance.
Okay.
Can you briefly describe the management of isolated variants, isolated thelarch, adrenarch, and minarch?
Yeah.
Okay.
So isolated thelarch.
If you want to take 1 minute to organize your thoughts, it's okay.
Okay, ma'am. Yeah. Okay.
All right. Yeah. Fine. Okay, Dr. Kazi, you can start.
Yeah. Can you hear me? Yes.
Yes, the voice is
Yeah.
very clear.
Okay.
Yeah.
So yes, ma'am. Regarding the isolated variants, so we have the three isolated variants: the thelarch, puberc, adrenarch, and the menarch. So this thelarch. So regarding why it is isolated, so as we know that all the other features here, it will be only isolated features based on what we are saying. So if thelarch, it will be only the breast development, as we are maintaining checking this thelarch with the tenor staging. So it will be tenor stage 3 and above before the age of 8. In case of the history, so we will take all the other history, but we will not find the other features of the causes of the central precocious puberty and the peripheral precocious puberty. So we'll exclude all the causes and the risk factors. And here we may find only one cause, that is the ovarian cyst formation. So here this ovarian cyst will secrete the hormones, and the breast tissues are more sensitive to these hormones. So this is the transient one. And to diagnose it, we will do the GnRH, the stimulation testing, that is the LH-RH stimulation testing. And here the difference is we will find the prepubertal features. That is, here we will find the FSH is more than the LH. Whether it is in comparison of the central and the peripheral, there we will, in case of central, we will find that it is LH and FSH ratio is more than 1. But here we will find FSH is more than the LH. So this is the differentiating point here. For the treatment, we will reassure the mother, but here for 14 out of 100 cases, it may develop into the in the future the central peripheral the central precocious puberty. So that's why the follow-up is very important. We will follow up the patient after 6 months, and for the follow-up, we will check her physical growth, including her the tallness, that is the body growth, as well as her all the other features like general examination of all the other features of the thelarch and the axillary hair and the pubic hair, as well as psychological impact and the social impact, as well as the biochemical features we will check. Whether it is going reverse, that is the LH is going more than the FSH. And we know that if it is more than 8 international unit per liter, so it is diagnostic of the central precocious puberty. So that time we can say that 14% is transferred to the central precocious puberty. So that is about the isolated thelarch. Now going to the isolated pubert. So we know that this is the development of the pubic hair. So here it is also isolated one, meaning that all the other features we will not find here. Only the specific this pubic hair will be more. And here our management will also be the reassurance, because there is no specific reason for this. And we usually will follow up these women because it is within 1 or 2 years it will be resolved. So we will at least follow up 1 to 2 years, but maybe longer. And will involve in the treatment the patient family members, immediate carer, like other parent, or if she is adopted. So this one will be the carer as well. So here the follow-up is very important. And in case of menarche, again, this menarche here, only the menarche feature will be there, and no other features will be found. But I would like to here include one point here in case of thalar, that if we find that there is any other features with the pubert and the adrenal, in terms of in the vaginal examination and the pubic hair, if we find that features of congenital adrenal hyperplasia, or the virilization is more, so we can test here with the 17-hydroxyprogesterone, dihydroepiandrosterone sulfate, and the dihydroepiandrostenedione, and the ACTH stimulation testing to exclude the other adrenal causes. So it will be diagnostic if we find this one. So this is important in case of isolated thalar, to follow up whether it is adrenal cause and whether it is going towards the peripheral precocious puberty. So that's why the follow-up is important. Now coming to the isolated menarche. So in case of isolated menarche, only this is only the menstruation will be starting earlier than the 8 years of age. This is will also reassure the mother that it will also go on its own. We'll only follow up her. And the cause is usually thought that the endometrium of the uterus, it is more sensitive to the other children. So that's why the bleeding is starting earlier. So if we find any other features, so we'll think about that, and we can do the ultrasound to check the ovary and the uterus specifically, to check the uterine endometrial thickness, uterine size, and also the volume of the uterus, as well as the ovarian features.
Yes,
So
okay.
that's the
And in menarche, one very important patient safety point is we have to exclude child sexual abuse if she comes with isolated menarche, isn't it? Because she is just coming with the bleeding, so we don't know what. There will not be any other secondary sexual characteristics. Yeah, like you told, it will be the only isolated finding. So if such a young, small girl is coming with bleeding, then we have to exclude child sexual abuse.
everything. Yes.
Yeah, right? Okay.
Mhm.
If needed, examination under anesthesia can also be done.
Okay. Okay.
Yeah. All right. Very well done, all of you. Okay, so just wanted to make it little interactive because all of you volunteered and I arranged this session on a very short notice. Okay, so let's discuss Khushbu's question. Okay, so differential diagnosis. So if like we always start the structured discussion with this S bar. Anyway, even if you can straight away start with the differential diagnosis and the causes, it will also save you time because already the scenario is given here. If examiner asks you, can you summarize the case? Then yes, you can summarize the case using the S bar. But here, yes, you can go and start with your differential diagnosis. Right, so let's discuss the answer. I will take all the questions in the end, okay? So yes, your introduction only, and what could be the differential diagnosis and cause of a condition. So in this young girl, it can be, yes, most important differential diagnosis is precocious puberty. It can also be because of hypothyroidism, any adrenal or ovarian tumor, exogenous steroid, even McCune-Albright syndrome. Because as of now, we don't know whether it is central or peripheral precocious puberty. All right, so most likely it is because of precocious puberty, because as per definition, precocious puberty is development of secondary sexual characteristics before the age of 8 years in girls. Now, what could be the causes? So it can be mainly central or peripheral precocious puberty, not isolated variants. But I've just written here just to know the types of precocious puberty, because in isolated variants, we know there can only be pubarch or adrenarche or menarche or thelarche. So what could be the causes of central precocious puberty? Most common, idiopathic is more than 74%. And they can be seen as pathology, like tumors in the brain, like hypothalamic hematoma, tumors like craniopharyngioma or astrocytoma. It can be because of congenital disorders like hydrocephalus. Acquired causes like post-infection, meningitis, encephalitis can be after head trauma, radiotherapy or chemotherapy. So Khushbu enumerated, you told all these causes. And peripheral type, that is the GnRH independent type. So it can be because of ovarian causes, adrenal causes. They can be estrogen secreting tumor like granulosa cell tumor, functional ovarian cyst, androgen secreting tumor like Sertoli Leydig cell tumor, adrenal causes, congenital adrenal hyperplasia, Cushing syndrome, or even adrenal tumors. They can be long-standing hypothyroidism, McCune-Albright syndrome as well. Okay, and isolated variants, just to remember the name, and then we will discuss the management in the end. So premature thelarche, menarche, pubarch, or adrenarche. How will you gather more information? So information is always history, examination, and investigations. So first of all, yes, I will introduce myself to the young girl, confirm her name and HS number, develop a rapport, gather information from both the girl and the parent. Would like to see the girl alone. This is also very important because it can be because of child sexual abuse also. So would like to see the girl alone. Very important, patient safety. Would like to know the detailed history to know about the onset, whether there was sudden and rapid onset of the changes. So it can be indicative of tumors like estrogen or androgen secreting tumor. And if there is any history of head trauma or infection, so it is indicative of cerebral pathology, like any history of meningitis, radiotherapy to the brain, or any surgical treatment. Would like to know about symptoms like headache, seizures, visual symptoms. These are indicative of space-occupying lesion. Thyroid symptoms like lethargy, any change in weight or appetite, any intolerance to heat or cold. And if there is any abdominal swelling or heaviness, because it can be because of any tumor like adrenal tumor, urinary or bowel symptoms, any urinary infection, then medical history. So I would like to know whether she's having any other medical condition, skin condition, like if there is any brown pigmentation, which is indicative of cafe au lait spots, and it can be found in some familial syndromes like McCune-Albright syndrome or neurofibromatosis. History of bone fracture, because it is common in McCune-Albright syndrome. We know there is this polyostotic fibrous dysplasia. Medication, yes, if there is any topical or systemic use of sex steroids, estrogen or androgens, chemotherapy, and of course, we have to rule out allergy. This is a patient safety point. What about her food habits? Whether she is having healthy, balanced diet, fast food, cosmetics. They can also be having some steroids maybe mixed in them. Family history of precocious puberty in her sibling or in her mother, and whether she has enough support at home. Social history is important if she is an adopted child, or whether there is any evidence of child sexual abuse, whether she's having any psychological and behavioral issues like poor body image, whether there was any growth spurt, whether she received any treatment, how about things at school, her peer group, and whether she feels safe at school and in her family. Then comes your examination part. So examination will be done with her permission, or like if her carer is there or the mother is there, so with their permission and in the presence of chaperone. So it's going to be head-to-toe examination, assess her general condition, measure the height and weight and BMI, examine skin for brown cafe or olate spots, examination of the breast, axillary and pubic hair to confirm the Tanner staging, neurological examination, so it has to be done by neurologist. Eye examination will include visual field examination and fundoscopy done by ophthalmologist. So you can just involve other colleagues. This will just fetch you marks in your communication with colleague. Abdominal examination to assess for any mass or any swelling. It can be like there can be ovarian or adrenal tumors. Examination of external genitalia. Assess the signs of virilization like clitoromegaly, deepening of voice, or hirsutism. Then comes your investigations. So mainly investigations are indicated by clinical assessment. And we have to assess the growth velocity and bone age first. So we do the left wrist X-ray. Anyone knows why we do the left wrist X-ray and not the right one? Why left only? Actually, there isn't any scientific cause. The only thing is that there will usually right hand is used most of the time. So there can be some mini fractures, hairline fractures, so there can be because of excessive use. Maybe the result won't be as accurate as it should be. So that is why, and just for the uniformity, that's all. And if, of course, any person is right, like he is already using, he's left-handed, then the right hand X-ray is done, okay? Yes, this is for the standardization, exactly. Now, if there is rapid growth velocity and advanced bone age, then two types of precocious puberty should come in our mind, central or peripheral. Because in isolated precocious puberty, growth velocity and bone age, they are normal. They're not advanced, except in isolated adrenarche. Okay, we will come to that point also. So whenever we assess this, like whenever assessment is done and we see there is rapid growth velocity, advanced bone age, now we have to differentiate between central or peripheral precocious puberty. So how to do that? Obviously, we will doing the hormonal investigation. So baseline serum gonadotrophin will be most of the time raised in central precocious puberty, and it will be low in your peripheral precocious puberty. And gold standard test is the GnRH stimulation test. And what happens here? GnRH bolus is given and LH and FSH are measured sequentially. So let's first come to this one where when there is LH predominance, LH is to FSH is more than 1 or LH is more than 8 unit per liter, like many of you told this range. So this is diagnostic of central precocious puberty. Now, if LH response just exceeds FSH, then it is in healthy pubertal children. And if FSH response exceeds LH slightly, so this is also in like prepubertal and in the Thilarch variant, because Thilarch, we know, like it is FSH dependent, isn't it? There is breast development is mainly because of the FSH. Now, if FSH and LH is low, GnRH test reveals flat response. This is diagnostic of peripheral precocious puberty. All right, so just to know what other tests can be done, which can help us to know the causes of peripheral precocious puberty. So yes, we can do the serum estradiol or testosterone. Sometimes result can be variable. Adrenal steroids, important one is 17-hydroxyprogesterone. If it is raised, it is indicative of congenital adrenal hyperplasia. Then dehydroepiandrosterone sulfate, of course, it is indicative of adrenal tumors. ACTH stimulation test, and if there is steroid synthesis defect, this is indicative of congenital adrenal hyperplasia. Thyroid function test, low thyroxine, high TSH, indicative of hypothyroidism. Then serum prolactin can be done, and it may be raised in chronic hypothyroidism and in McCune-Albright syndrome or prolactinoma. Usually raised serum prolactin is indicative of delayed puberty. Urinary steroid profile if needed, just to identify and quantify excess adrenal androgens. Imaging is important. So whenever like we see there is increased growth spurt, bone age is advanced, and GnRH stimulation test is showing that LH is raised, So it is indicative of central precocious puberty, isn't it? So now we have to do some imaging, the cranial MRI or CT scan to assess for any cranial pathology which can be the cause of central precocious puberty. Then for peripheral precocious puberty, we can do the CT adrenals, pelvic ultrasound scan also to assess the size and shape of uterus, endometrial thickness, any ovarian morphology. And DEXA is important to assess the bone age, and bone scan in McCune-Albright syndrome, because there can be multiple, bony lesions, cystic lesions in the bone is seen in the McCune-Albright syndrome. Now, she has been diagnosed with idiopathic central precocious puberty. So how will you manage her? So whenever condition is diagnosed, then we have to explain the condition. So we're going to explain it to this young girl or her carer or her mother. MDT involvement is a must. Pediatric endocrinologist should be involved in this case. Also, we will involve adolescent gynecologist, consultant, counselors, radiologist, specialist nurse, and the GP. And involve social services and safeguarding team if there is any suspicion of child sexual abuse. Very important patient safety points. And we know the mainstay of treatment is the GnRH analog. Now, when we are discussing about GnRH analog, we have to keep few points in the mind. We will discuss what is the goal of the treatment, how it acts, what are the preparations, what are the side effects, how are we going to monitor the response, when are we going to stop it, and when we stop, then what's going to happen, and whether we can include GnRH growth hormone or not. So goal of treatment, yes, regress or halt secondary sexual characteristics, prevent early menarche, improve the final height, avoid social or behavioral sequelae. Now, how to monitor the response? So, like you people said, yes, we will be monitoring the growth of this young girl and anthropometric measurements. So this will include checking her height, weight, BMI, even her psychosocial behaviors. Assessment of pubertal progression and bone age at regular intervals. Also, LH measurement will be done, because if there is suppressed LH response, this indicates that treatment is effective, because we know the LH will be is usually very high in central precocious puberty. Now, when are we going to stop the treatment? When it is time for the normal puberty to begin. And stopping treatment has to be a joint decision taken by the endocrinologist, parents, and child. Now, what happens when we stop treatment? So, suppression of puberty is reversible, because we are giving this treatment to suppress puberty. But now we have to stop the treatment so that there are going to be the pubertal changes. Reproductive function is usually unaffected. And on stopping treatment, pubertal changes reappears within months. Menarche will occur within 16 months of stopping treatment. Then just remember the GnRH preparations the examiner may ask. It can be long-acting or short-acting. Long-acting ones, we know leuprorelin, goserelin, triptorelin. How are they given? Subcutaneous or by IM injection every 3 to 4 weeks, or as a long-acting depot at 10 to 12 weekly intervals. Short-acting is neferelin, given as nasal spray and used daily, but it is less effective. Why? Because of difficulty in compliance, and it is not considered as first line. And yes, there is implant like Hysterin, which can also be used. What happens when we give GnRH agonist regarding the height? So there is modest improvement in final height between 6 to 8 years of age. There is no improvement in final height after 8 years of age. So there won't be any improvement in the height if it is given after 8 years. What about combined use of growth hormone and GnRH agonist? Yes, routinely it is not given. Use is controversial, but it may allow more growth in children who are very short or there is stunted growth. Again, it's going to be the expert decision. Adverse effects of GnRH agonist, it is patient safety. So in the exam, any adverse effect, any side effect, any complication of any medication, any surgical treatment, it is patient safety. There can be headache, hot flushes, mood swings, injection site reactions like rashes, bruising, and sterile abscess. Long-term use can lead to PCOS, but there is no adverse effect on the adult bone mineral density. And yes, when we are ending the station, we will say we have to give the support group number, give the patient information leaflet. And if any pathology is found on cranial CT or MRI, then we have to treat the pathology. All right, now just in brief, we will discuss the peripheral or pseudo-precocious puberty. So here, like it is uncommon in girls and mainly because of the secretion of sex steroids. There is rapid growth, advanced bone age, pubic or axillary hair and like clitoromechely is there. Bone age is usually advanced except in hypothyroidism. Treatment will depend upon the cause. So like we know for hypothyroidism, we can give thyroxine replacement. If there is any exogenous source of steroids, discontinue the source of steroid. Any tumor, adrenal or ovarian, so surgical treatment, radiotherapy or chemotherapy. For classical congenital adrenal hyperplasia, we can give glucocorticoid or mineralocorticoid. Non-classical hydrocortisone is given, and for McCune-Albright syndrome, aromatase inhibitor is given. Now coming to the isolated variants. So here usually growth rate is normal, bone age is not advanced. But in central and peripheral precocious puberty, there will be growth spurt and bone age will also be advanced. Assessment is usually normal. So if all the assessment is normal, we will just give reassurance, observation and follow-up every 6 months. Now coming to isolated thelarche, so we know there is only breast development without other signs of secondary sexual development. What about the etiology? It is unclear, but it can be because of ovarian cyst formation or increased sensitivity of breast tissue to normal levels of circulating estrogen. Investigations is usually not done in mild cases, and however, it can be done if there is like moderate to severe cases. Gonadotrophins and estradiol levels are usually within the normal prepubertal range. GnRH stimulation test will show FSH predominant response. And breast tissue, we know FSH predominant response means there will be increased estrogen and breast tissue will be more sensitive to this estrogen. Pelvic ultrasound can be done and it will just show uterine dimensions are appropriate to age and normal ovarian morphology or ovarian microcysts. What about the treatment? So only reassurance, careful follow-up every 6 months to assess the growth and to assess for other pubertal changes and to distinguish cases from those evolving into early central precocious puberty because like Dr. Kazi said, 14% of cases of isolated thelarche, they can progress to early central precocious puberty. That is why observation is important. Isolated menarche. So this is also an important one. Now here we have to see what are the causes of the bleeding in this young girl. So there can be causes which we are going to keep in our mind. It can be because of exogenous administration of estrogen, vulvovaginitis, foreign body, trauma, urethral prolapse, sexual abuse, very, very important to exclude, or rectal bleeding. So history has to be very meticulous, need to know about the bleeding, the onset, duration, and amount. If there's any abnormal vaginal discharge, we have to exclude any sexual abuse, any STI. And pubertal development. Then examination, it's going to be the general and genital examination, inspection of the external genitalia, introitus, urethra, in the knee chest position, and this has to be done in all cases to exclude significant pathology. Examination under anesthesia is important. If there is heavy vaginal bleeding or suspected vaginal trauma, foreign body, or tumor, or in cases where bleeding continues despite negative findings on examination. What about the investigations? Now, this bleeding young girl, so we are going to do full blood count, check the hemoglobin, genital swabs if indicated. If sexual abuse is suspected, pelvic ultrasound scan if indicated. So it usually shows prepubertal uterus and no endometrial shadow. Urine analysis to rule out infection, and if indicated, pregnancy test to rule out pregnancy. GnRH stimulation test, it will show the FSH predominant response. So menarche occurs because what happens that again, FSH means there will be high estrogen as well. So endometrium will be more sensitive to the estrogen, and that is why there is this bleeding. What about the treatment? So usually no treatment if we have excluded all the causes. Only careful observation and follow-up is done, and there is no long-term sequelae. Condition usually resolves in 1 to 2 years. Coming to isolated pubarch or adenarche. So it can be because of androgen excess. Clinical features will be like, yes, axillary hair, pubic hair, adult body odor, greasy or oily hair skin, and there can be mood swings. Increased growth velocity and slightly advanced bone age in cases of isolated pubarch or adenarche. But in other isolated variants, like your isolated thelarche or menarche, the growth velocity and the bone age is normal. And final height and onset of progression of puberty, they are not affected. What investigations? Like you people said, yes, if we are suspecting any adrenal tumor, because it can be because of androgen excess, so we can do the dehydroepiandrosterone sulfate. It may be sometimes slightly elevated, but all other adrenal steroid hormones will be in the normal range. We can go for sex hormones and GnRH stimulation test, and this will be in the prepubertal range. So what about the treatment? Only observation and follow-up. And symptomatic treatment will be done with, of course, regular washing. We can advise them to use deodorant for body odor, cosmetic methods for excess hair removal. So, follow-up is usually done till adolescence or even in the adulthood. And there is some evidence that isolated pubarch or adenarche, it is seen more commonly in premature babies or babies who were SGA, small for gestation age, even in obese patients, because we know there will be insulin resistance and sometimes androgen excess. So this is a diagram. It looks complicated, but it's very nice and very simple diagram. So whenever we see any young girl with premature sexual development, as we discussed, we are going to take the history examination. Now, examination, we will see, okay, thelarche is there, menarche, or any other secondary sexual characteristics. First important thing we have to do is we have to assess the growth velocity and the bone age. If there is rapid growth rate and advanced bone age, then we will consider it can be either central precocious puberty or peripheral precocious puberty. So how to differentiate the GnRH stimulation test and also the baseline FSH and LH levels. So in central precocious puberty, we know LH will be very high and FSH, LH will also be slightly raised. And in peripheral precocious puberty, there will be flat response to GnRH test. So now once central precocious puberty is diagnosed, so we have to find out the cause. What could be the cause? We are going to do the cranial MRI. And if it is normal, it is most likely isolated idiopathic central precocious puberty, and then treatment is going to be the GnRH agonist. But if there is any pathology found on cranial MRI, then we have to treat the etiology. Likewise, peripheral precocious puberty, so we have to find out the cause. Abdominopelvic ultrasound scan, it can reveal any ovarian pathology. CT adrenals can be done. And if it is normal, then we will, we can also suspect any exogenous estrogen source. If any abnormality is found, like ovarian tumor, adrenal tumor, then we have to treat based on the etiology. Then coming to the isolated variants like Thilark, Minark, and Adrenarch. Okay, so here the growth rate and the bone age, they will be normal. All right, so as we discussed in all these isolated variants, we will just reassure and observe. And follow-up is usually done every 6 months. Now, we discussed isolated this one, Adrenarch. So in Adrenarch, there can be slightly raised growth velocity and slightly advanced bone age. So it can be because of the androgen axis. So here we just have to exclude other causes of isolated Adrenarch. That can be congenital adrenal hyperplasia or can be adrenal tumors. That is why talk says we have to do the dehydroepiandrosterone sulfate. Okay, and just to exclude this adrenal tumor. And if it is completely isolated variants, nothing to do, only reassurance observation. Isolated Minarch, we have to be very careful, exclude the child sexual abuse as we have discussed. Okay, so I have tried to keep it as simple as possible. All right, so any questions from anyone? I have just opened the chat box. All right, yes, you people have written, okay. Name of drug, okay. So Dr. Mahmood has written growth hormone is not needed in most cases. Of course, not needed in most cases, only in stunted growth. And of course, it's going to be the expert decision, right? All right, any more questions? Thank you for your participation, and I will try to arrange another session on bullying. Okay, so again, I will, if whenever I'm a bit free and I get the time, I will arrange the session. Okay, so that's all for today. I hope the session was useful to all of you. Recording,
Yes,
yes, I will share after some time.
thank you, ma'am.
Thank you.
Thank you, ma'am. Ma'am, can you give us the list of topics like the talks? This is old talk, like 2012.
Mm,
Which should we
yes.
be doing?
Actually, no one expected that this scenario can come in the exam. So,
This was my first case, ma'am.
yes, yes.
Yeah.
Anyway, okay, I'll try to share the talk list year-wise. I will share it.
Yes, ma'am.
Okay, yeah, fine.
Thank you so much, ma'am.
Thank you. Thank you, all of
Thank you
you.
so much.
And the
Thank you, ma'am.
participants. Okay, thank you so much. Good night. Bye-bye.
Good night, ma'am. Bye.